This episode of the Geriatrics podcast is CME eligible.
To claim credit, please go to the CME tab on geripal.org.
Welcome to the Geriatrics podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we got a full house with us. Who's with us today?
Very full house today. We are delighted to welcome Jennifer Wolff, who is a health services researcher and gerontologist and professor at Johns Hopkins. Jennifer, welcome to the Geriatrics podcast.
It's great to be here.
We are also delighted to welcome Sydney D., who's a primary care doc, palliative care doc, and researcher and professor at Johns Hopkins. Sydney, welcome to the Geriatrics podcast.
Thank you.
And we're delighted to welcome Danny Scerpella, who's a research associate at the School of Public Health at Johns Hopkins. Danny, welcome to the Geriatrics podcast.
Thank you very much. Excited to be here.
And Jasmine Santoyo-Olsson, who's a social behavioral scientist and a fellow in the T32 Research Fellowship at the UCSF Division of Geriatrics. Jasmine, welcome to Geriatrics.
Thanks.
So we have an amazing lineup of guests, and we're going to be talking about a pragmatic study on advanced care planning, which we'll have links to in our show notes for the actual article. But before we dive into the study and the implications it has for the practice that we do, I believe someone has a song request. Jasmine, is it you?
Yeah, it is me. It's called Laka Laka, which is a mariachi song, and it translates to the skeleton. And the reason I chose this song is because, I'm currently working on bringing advanced care planning sessions to the Latino community. And, in our planning sessions, one of the biggest barriers to advanced care planning in this community is just talking about death. However, if we think about that death is actually already embedded in the Mexican culture. And, culturally, death is not something to fear, but rather something to embrace and even celebrate. At least that's the way Mexicans see it. And so this perspective actually helps affirm that it's okay to talk about death. And so we're actually starting our advanced care planning sessions with music that talk about death. And, in a way, it gives, participants permission to engage in discussions about dying. And so this is our way of supporting non-English speaking families in advanced care planning. So that's why I selected the song.
Great. Alex?
All right, this was a fun one. Get to learn some Spanish for this one. Went over it with Jasmine yesterday. I've had fun relearning Spanish recently. Took a trip to Mexico City. Still suffering from some illness from there, which is why I was sick and not in the office with Eric today. But here's a little bit of the song without a full mariachi band. Mucho cuidado, señores, porque la muerta anda lista en el panteón de dolores. Ya nos tiene una posita para los compositores y uno que otro periodista, licenciados y doctores, todos están en la lista. Tucu tucu tiquitaca, que ranca y jacalaca, cuando menos lo pensamos, nos hace estirar la pata. Yo me escapé una vez, pero por poco y me atrapa.
Thank you, Alex. And thank you, Jasmine, for that great song. How did Alex do?
He did great.
Yeah, I love that. That was great.
Very generous. Thank you.
Okay, we got a lot to talk about. And interestingly enough, this is a really fascinating study that just got published in JAMA IM in December of 2024. I think that the most interesting parts of this is, I think we got to hear what happened in this study, but what do we do with the results? Can't really talk about that until we talk about why did we do this study and what did we do. So I'm going to turn to you, Jennifer, first. So it's great. You're a first author of this publication, JAMA IM, on a pragmatic study of advanced care planning. Why did you even bother doing this study?
Yeah, thanks for the question. It's a great question. And boy, we have come a long way from writing the proposal in 2018 to where we are today in implementing a pragmatic trial using largely virtual modalities. When the proposal that we wrote was really geared towards thinking about supporting older adults with and without dementia in primary care, and using embedded advanced care planning facilitators who would be physically embedded in the clinic. So a lot has changed, but what motivated the study was a recognition that most advanced care planning interventional research had been undertaken in nursing homes, but most people with dementia are initially diagnosed and medically managed in primary care. And they really desire clinicians to initiate these conversations. But there are a number of really important barriers for these conversations taking place. So we proposed and used a existing manualized protocol respecting choices, which had a large evidence base, but that had not previously been studied in the context of dementia. And what was notable for me and what really drew me into this space was a recognition that advanced care planning is a longitudinal communication process that ideally engages surrogate decision makers in repeated conversations. And I have a long interest in identifying family caregivers and supporting them in care delivery. And so this was really, in my view, a perfect window for reinforcing the role of family in primary care.
Great.
I'll stop there, and I'm sure Sydney may want to chime in. She's been a great partner throughout the proposal writing process and the study.
Yeah, Sydney, you're the senior author.
Yes.
Let me ask you this. Why was this study important to you? Why did you want to do this study?
For me, so I've been developing and running palliative care and hospice programs at Hopkins for about 25 years, and advanced care planning is such an incredibly important part of that. And we know that advanced care planning hopefully has more benefits than risks for people, but that there's so much more that we need to do. And so it's just wonderful to partner with Jennifer and the really important pieces about how we don't pay attention to cognitive impairment and dementia, and we don't involve the family enough in these conversations, especially in our work in primary care.
All right. So I'm hearing what's important. I'm hearing dementia patients or patients with dementia. I'm hearing family and caregivers. Danny, I'm going to turn to you. What did you do in this study, and did it focus on those components?
Yeah, definitely. I mean, it's one of those things where I'm going to have to watch myself for time because we could go on about this for a long time. It was a massive undertaking. The intervention itself is very straightforward. I think the elements are strong and they make a lot of sense. But the process of implementing this project across two big health systems in our area was very complicated and had its share of both challenges and rewards as we went through this process. I would say that the first and most difficult part was kind of forging those partnerships with leadership within each organization, understanding, this is pragmatic. So the idea was we want to meet them where they are, follow their priorities, make sure that we're not stepping on the toes of any existing initiatives or, metric goals or things like that. So ultimately, we had to get buy-in at a high level to sort of step in and start, tinkering with workflows that, are kind of, as healthcare is a giant machine in primary care.
And that's because you randomized clinics. You didn't randomize patients to interventions. Is that right?
That's right. Yeah, we did it by the clinic level, and so everyone who's in that clinic was the intervention was available to them. But there wasn't a push. There wasn't we weren't cold calling people and telling them to be part of this. They all received a similar mailing, which basically served as an advertisement for what we were doing. The resources available within the clinic and those resources that were part of this study were never advertised as sharing choices, which was the name of the project. They were offered as usual care in those clinics. So they were just additional resources that we were trying to say. So
and then who were the patients just with dementia, or were they every patient independent on age? Who was included?
Yep. So we emailed to everyone 65 and older with an upcoming visit. We had a sort of a staggered mailing thing, but generally when people would schedule a visit, whether they actually came to it or not, that triggered a mailing to those people. And it was the different materials that we have. It was a letter from the clinic introducing it. It was information about our ACP facilitator. There was an advance directive, a blank one in there for their records, a patient and care partner checklist that was meant to be filled out before a primary care visit. So we sent that to everyone 65 and older with upcoming visits, though we were tracking on our side, like the different, like the people who had diagnoses and things
so
like that.
So the hope was that the facilitator would talk about advanced care planning before the primary care visit.
Yep. That was the goal. And as you can imagine, there's a lot of complexity around that. So one of the biggest challenges that we got, and I'm sure this is true of many, many studies over the last 5 years, but just as we were getting ready to launch this study, the COVID-19 pandemic hit, and we made a decision to continue and push through with the trial. But it required a big shift from what we originally planned, which was that these facilitators were going to be in the clinic, meeting with these people face to face. So some of our approaches definitely altered based on the availability of what we could get done. And so a lot of it was the facilitators calling out with the approval of the provider to the patients ahead of time to see, like, you have a visit coming up, this is what I do here. We're just trying to do this for all patients. How can we have this conversation with you today? And that obviously brought up its own challenges as well.
And can I ask, are any of you respecting choices facilitators? Like, what's included? Like, what happens when the facilitator meets with the patient?
Yeah, I mean, I'll speak, but Jennifer and Sydney, feel free to jump in. We all got trained at it at the beginning. So we all sat down and got the training. It was a really interactive kind of thing. But essentially, it is a conversation guide. There's I want to say it's been a while. It is about 5 or 6 things that you go through and you cover the different topics. It goes into things like, what is advanced care planning? What's an advanced directive? What does it include? What does it mean? What doesn't it mean? You kind of go through the different life-sustaining treatments, things like CPR, and you ask about what people think about that. And then you there's also education that goes with it, educating, what does that mean? Like, in a real scenario, I don't think a lot of people understand what CPR is outside of what they see on TV, where it's sort of like this miracle thing that everyone does, and then people sputter back to life.
Does it talk about outcomes, like the outcomes of CPR, and is it at all individualized to the patient?
I don't know how individualized it is. And Jennifer, if you go ahead, Jennifer. Yeah.
So the conversation guide is meant to be delivered by non-clinicians. And that was one of the reasons that was appealing to us, is that the conversation guide could be delivered by lay facilitators in partnership with the clinical practice. So the idea is to really normalize advanced care planning as part of clinical workflows. And Eric, you asked about whether the ACP conversation would happen before. We were agnostic on the timing. Ideally, the conversation would happen before, but also clinicians were able to make referrals to facilitators. The broader idea was to try to motivate conversations to occur and to also allow patients to bring in completed advanced directives if they had, one that already had been developed outside of the ACP facilitator conversation. And you mentioned whether we were targeting just people with dementia.
Yeah.
And we did not do that because dementia is so often underdiagnosed and there's a lack of awareness. So we tried to normalize advanced care planning as something that was available to all older adults in the practice. And we did not introduce it as advanced care planning, but rather a communication initiative, laying out a variety of strategies that patients and families could use to improve communication with primary care clinicians and the team. And that included scheduling a visit with a facilitator who had been specially trained. It included the patient family agenda setting checklist, and it also motivated the idea of the patient portal and shared portal access for care partners who would then have their own login identity credentials, because we recognize for people with memory impairment, often that can be an important way of facilitating interactions between families and clinicians.
And the caregiver was encouraged to be at these facilitated meetings?
Yes.
Okay.
As often as we could.
Yeah, can I ask Sydney, when you did the training as a palliative care doc and primary care doc, how did this seem similar or different from what you do in primary care or palliative care?
So I think what you're asking about somewhat is what you do in a trial and what health systems want, and what we do for quality metrics is often just really different from what we're doing as as physicians, I think that these pieces about making sure that we're engaging families, making sure families are aware of what's going on, these are all really important parts of advanced care planning. But doing a protocolized advanced care planning that's focusing on advanced directives and having the advanced directives as an outcome and meeting those quality metrics, those are pieces that maybe in an ideal world, like Jennifer is saying, and Danny, we would be able to be more flexible and individualized, but that's not necessarily how a pragmatic clinical trial that you're doing across a couple of health systems and need to get leadership engagement is able to work.
And Danny, I'm going to go back to you. So you randomized clinics. You didn't randomize the patients. So all the patients in that clinic over 65 were included. Real quick, when you measured the outcomes, was it in everybody in the clinic or just those who got the intervention, who got the actual facilitation? How did you think about your primary outcome and what was it?
Yeah, that's a great question. And I'm going to be looking at Jennifer to back me up. But I think the main idea is we wanted to look at the effect of patients who were in the intervention group versus those who were in control clinics who are just getting usual care. We were extracting data for all those people, but we weren't doing anything in those clinics. So that's the first part of it. For like the end-of-life care, the potentially burdensome end-of-life care, we definitely looked at patients who had serious illness, which is a designation that we were able to use through different procedure codes and diagnoses that patients had. But we were very much looking at what happened in the intervention clinic versus the control clinic for the outcomes.
So Jennifer, going back to that, this was the intention to treat everybody in the clinic, or was it just those who actually got the intervention?
No, it was all patients who had a scheduled visit at the intervention or the control clinics.
Okay.
This was at two systems, and we did look at the extent to which there was overlap. I think we excluded a few patients that were, I can't remember actually. There were very few patients that were seen in both groups, and I believe we did sensitivity analyses, but they didn't.
So this is a true pragmatic study. You're going to do this intervention in these clinics. You're going to randomize the clinics, and you're going to see what the outcome is. What were the two outcomes that you were looking at again? The big ones?
Documentation of end-of-life preferences. Initially, we proposed only looking at documented advanced directives, but our two health system partners felt strongly that we needed to include the MOLST. So we ended up with a composite measure at their request. And so that was across all older adults who were established patients of those clinics. And we looked at newly documented end-of-life preferences. So for patients who had a documentation at baseline, they were excluded from the evaluation of the outcome.
I'm just going to clarify for our listeners who may not be familiar. MOLST in this case is probably the Maryland Orders for Life-Sustaining Treatment. MOLST. Great. Thanks. Go ahead, Jennifer.
And then Sydney was very involved in making decisions about our second outcome of potentially burdensome care at end of life. So she would be the best person to speak to how that measure was operationalized and why.
Sydney, what's a potentially burdensome intervention at the end of life?
So this is a way to look at the outcomes that you would expect directly related to advanced directives and similar to most other trials and standards that are out there. So it's looking at things that you would expect that someone who, again, ideally trying to define the population with serious illness who might not possibly want these interventions. So intubation, CPR, feeding tubes. And a real advantage of our study, something that Danny worked really hard on, is that in Maryland, we were able to look at these as statewide outcomes. So we were able to pull information from the Health Information Exchange to be able to look at whether this happened at any hospital in Maryland.
So it was interventions like feeding tubes, mechanical ventilation, like dialysis at the very end of life. Like, how is it actually defined? Like how close to the end of life? How, is it all just in seriously ill patients? I guess like if somebody just drops. Can you clarify that for me?
Yes. So within, and Jennifer and Danny, correct me if I'm wrong, I have it all pulled up looking at the specifics. It's within 6 months of the end of life for people who have a serious illness. So someone who has, for example, advanced cancer, as well as we can define those with ICD-9 codes. Again, a similar outcome that people are looking at in a lot of other advanced care planning trials. This is a pragmatic trial, so we have to collect what information we have available from Health Information Exchange and electronic health records. We're not collecting any of this information directly from patients.
And Danny, how many different interventions were included on this list of potentially?
Oh, that is the question. It's a lot. I mean, actually, when I say that, I want to put a caveat. There's a lot of ICD-10 codes. If you give me a second,
but the big ones are like intubation.
Yes.
That's right. That's
CPR,
dialysis. Okay.
Yep. Mm-hmm.
Yeah, those are the big ones. And I think in our analysis of like what were the most common, which we've done since the paper, intubation was by far and away our most common procedure that happened across all patients.
And intubation will last 6 months of life.
That's right.
All right.
Correct.
So let's
recap for our listeners. The first outcome was documentation either in the form of an advance directive or a MOLST, which is Maryland's form of the POLST, Physician's Order for Life-Sustaining Treatment. That was number one. And number two was potentially burdensome interventions. And those are things like intubation near the end of life among seriously ill patients.
All right, let's jump into Sydney. What did it show? Let's stick with the first one. Did it increase documentation?
Yes, so we did find increased documentation of the primary outcome in the electronic health records. The effect was really for advanced directives and not for the MOLST or POLST.
And that's new documentation. If they had an advanced directive before and they did it again, did that count?
Well, it's what's in the electronic health record.
Okay.
So yes, what's in the electronic health record. Yes.
So advanced care planning, pragmatic advanced care planning intervention works.
For documentation, it works. It works great. Yeah, we saw very strong effects for newly uploaded advanced directives and the like. And yeah.
Wait, could we just say the numbers so we know what the absolutes are, roughly?
So in our adjusted models for uploading a new advanced directive or MOLST, so we did it as a combined outcome, as well as looking at it as just the advanced directive alone and the MOLST, I believe, alone. But for the combined one, in our adjusted models, we had about 2 times more people in our intervention groups were 2 times more likely to have an advanced directive or MOLST uploaded compared to people in a control trial. If you're just looking at new advanced directives in the same cohort for our full cohort, they were almost 4 times as likely to have an advanced directive versus people who were just in the usual care control arms.
So big relative difference, but I wonder if anybody has the absolute numbers, because I remember thinking, wow, that's kind of a modest proportion of people who completed an advanced directive after this trial. Okay, I've completely sidetracked us.
No, you're looking for the proportion, right? Like of people.
Yeah, like how many people got an new advanced directive? Like what proportion?
We have the composite measure, we have the advanced directive measure, and then we have subgroups as well, which I think was also, an important point. You didn't ask about it, but for us, it was very important to examine differences for older adults with a diagnosis of dementia. And then we also looked at subgroups who are 75 years and older. We looked at sex, and we also looked at race. And it was important to us to examine those differerences, and we did find that the effect held across those groups, though the effect was disappointingly attenuated, which I think is sort of, was to us an important outcome.
Yeah, and I think it was a 6% difference between the group as far as documentation. 12% in intervention, 6% in those, so 6% difference. How many people in the intervention group actually got the facilitation?
So everybody got the outreach, everybody got the mailing with the information. About 5% of people did participate in facilitation conversations with the advanced care planning facilitators. And that's pretty similar to a lot of the respecting choices other respecting choices studies that are out there.
Okay. So they all got some of the intervention. About 5% got the facilitated part of the intervention versus kind of the usual care group. And that led to about a 6% absolute difference in advanced care planning documentation. Did that result in decreased burdensome treatment at the end of life?
All right. So I think I'm up for answering this question.
Yes, you are.
So, yes. Okay. So we found that, again, this is intent to treat in the practices, that the intervention practices actually had higher rates of potentially burdensome end-of-life care than the control practices.
So in that, I'm just going to read the numbers I'm seeing. 28.8% in those decedents who got the intervention versus 20.9% in the control practices. So kind of about the same magnitude. That's really interesting. So advanced care planning documentation increased, which potentially resulted in increase in burdensome treatment at the end of life. Did it matter if you had dementia or if any other demographics changed that?
It did not. And again, so we had a great editor, JAMA Internal Medicine, who spent a lot of time helping us with all the details of the published article that you see. And it's pretty clear that again, the numbers of uploaded advanced directives are small. The number of facilitated ACP conversations were small. And we also published a qualitative paper where we spent a good bit of time talking to people who were participants in their intervention about their experiences. And it's pretty clear this was a clinic level effect, that with the small number of people who had new advanced directives uploaded and the small number of people who had conversations, that did not account for the changes that we saw in potentially burdensome end-of-life care.
Yeah.
Okay. Go ahead, Danny.
I was just going to say just one extra piece that I think is worth mentioning in this is that, we saw the strong effect in the advanced directive uploads. But for our potentially burdensome, we were looking at the clinic level. So we weren't specifically looking at only the people, and like to Sydney's point, these populations were small, the people who actually did upload a document or who did have a conversation. So I think it's important to note that this was at a clinic level. There's probably a lot of variation beyond clinics, but it also makes it very hard, because this was so pragmatic, it made it very hard for us to understand the mechanisms of why we were seeing what we're seeing. I mean, I think this is a really rich thing to look into, why did we see this? But I think it's also difficult from the data that we had and how pragmatic this was to understand exactly why we're seeing that effect.
So Jasmine, you were tasked with writing the editorial for this, which we'll have show notes to. We'll have a link to the article. When you first saw these results, were you surprised, or do you think, oh yeah, that makes sense?
Yeah. I was very surprised by the results that you showed, because I was expecting to see the opposite effect. But I guess one of the points that I brought up in my commentary is that, and you all brought up an important point, is, it is a pragmatic trial. But the way that I described it is, it's possible that the advanced care process or the documentation actually aligned with those instances of burdensome care that actually reflected what patients actually wanted in terms of their goals, their preferences. And so I think this actually kind of suggests that individuals actually received the care that they wanted, even though it's not what we would think that they would want, but it's possible that their goals were met in terms of the care that they received. And I don't know. I'm curious.
So what I'm hearing potentially is that while it's labeled potentially burdensome care, maybe it should be labeled gold-aligned care potentially.
Yeah. I mean, we don't know. I mean, it's a pragmatic trial, so but it's possible.
Yeah. Thoughts from the rest of the group on that, Danny?
Yeah, no, I was just going to say this is a conversation I've had with a lot of colleagues at different conferences and things like that. And one thing that would be awesome to do, but in the current like way that this is done, it's almost impossible, is like, examining goal concordant care for people who died. And the issue with that is that especially the way that like the advanced directive is usually stored in the EHR, I mean, among a multitude of issues that we had to, untangle, but at best it's a uploaded PDF document. So if you want to like examine, did the care match the thing, you got to go in yourself. And then when you start to get to these huge numbers that we're dealing with in some of these cases, like the idea of doing that is really hard to piece out. So I don't think, and I could be wrong, but I think doing this at a scale, at like a huge scale for people who died and seeing how their care was aligned with their wishes based on the actual document, I think it's a really cool idea. Maybe with the advent of large language learning models or AI or something, it would be more possible. But yeah, as it was, it's something we thought of, but it's just almost impossible to do.
Well, it was an interesting thing is 1,500 deaths in both groups. I don't know how many of those actually had an advanced directive in file, but it'd be interesting to know what was written in that advanced directive. And again, I think it's hard even when we think about advanced care planning, because like we talked about the definition, it's a process, and this is just a document of a snapshot of that process.
Yeah. I actually have that number if you want it. Oh, sorry. Go ahead.
Yeah, go ahead, Danny. What's the number?
Well, it's not the hard and fast number. There's some, tweaking that would be done, but I have the number. So we had roughly 3,000 people die. And during that time, and this is regardless, this is across everything, control, intervention, everything. About 550 had an advanced directive uploaded to the EHR, importantly, at least 6 months prior to their death. So that's just a raw number.
Yeah, well, I was just going to say, and again, our great editors really asked us about this as well, and the numbers are really small. So the numbers who had an advanced directive uploaded and died with a serious illness, it's just really small numbers to look at. So I think the bigger question really is what maybe happened in the clinics or for the care of people overall during this time. Could there possibly have been something that happened as part of the pragmatic clinical trial and very complex difference between health systems, clinics, all of that led to this clinic level finding? And
Jennifer, your thoughts?
Well, I was just going to pile on that we're in a no-cost extension. And in this time period, we're leading a number of papers that are focused on really trying to unpack a little bit better some of the implementation differences across clinics and really trying to understand especially the connection between advanced care planning, advanced directives, and for those who died, receipt of potentially burdensome care at end of life, to try to better understand some of the findings that we observed in our main paper.
So, Jasmine, let me ask you this, is that we just did a podcast with Yael Shanker about a study she did on respecting choices versus prepare for your care. That is yet to be published, but it was presented at the AHPM annual meeting. And, their outcome was whether or not their engagement scores with advanced care planning. It wasn't, their primary outcome wasn't documentation or potentially burdensome benefit or burdensome interventions. What outcome should we be looking at when it comes to advanced care planning studies?
There are different outcomes, but I think something that I think is lacking in at least in this study, and I know why it's lacking, but sort of like looking at the preparedness of the decision maker, whether or not they felt ready to make those decisions in the moment. And I think another big aspect.
And wait. So when you're saying preparedness, you're not saying preparedness to complete advanced directive. You're saying when the time came to make a decision around a serious illness, like should I intubate or not? Are they prepared to make that decision?
Yes, that's what I'm saying.
Yeah.
And then another outcome, which I think is also important, is, sort of the psychological impact that sort of making these types of decisions has on a family member, caregiver, and these outcomes include things like depression, post-traumatic stress, complicated grief. All of these things I think are important because, it's important to document, but I think it's also important the impact that the position that we put caregivers in to make these, decisions.
So I'm hearing it, going back to Jennifer, how important the caregiver is in all of this, and getting caregiver outcomes in bereaved patients. So that population of patients that were bereaved, what were their PTSD symptoms? How prepared were they to make these decisions? Is that possible at all in this study, or is the pragmatic design, it's just not going to happen?
Yeah, the challenge of the pragmatic trials is the necessity of relying on data collected in routine care. We originally did propose a subset of caregiver interviews, but just it wasn't possible. And part of the focus of the intervention was on trying to engage care partners through being registered for the patient portal. That's a whole nother conversation that's very challenging. Uptake of shared portal access, where a patient sort of confers the ability for a care partner to have their own identity credentials to access the portal, is a way that could be used for collection of caregiver reported outcomes, but it has been very difficult to execute in routine care. I will say that we are wrapping up a sister study of advanced care planning that was an efficacy study where we enrolled older adults with cognitive impairment and their care partners and are following them through 24 months and bereavement. And we are collecting a whole host of care partner reported measures, the ones that Jasmine just listed. So we will be able to get some insight on this, but it was not possible in the design of this particular study sharing choices.
Okay.
So can I give my my thoughts on the bigger picture here? And
what's the big picture here, Alex?
Everybody's thoughts? All right, here are my reflections, and I'm interested in what your reflections are. You're probably aware of the big controversy about the worth value of investing in advanced care planning and advanced care planning research. I see everybody's nodding their heads, and we've done several podcasts about this. And I'm sure Sean Morrison, I'll speak for him. All right, Sean, sorry. I'm speaking for you. Probably like, oh, see, I told you, right? Like, look,
advanced care planning doesn't work. You can increase documentation and it worsens burdensome interventions.
Right. And so that's one perspective. And then I think the middle author on that paper was Diane Meyer. Hi, Diane. Hope you're listening. I remember seeing a video of Diane in a congressional hearing. And somebody said, what is palliative care? And she said, palliative care is matching treatment to patients' goals. And then this congressperson turns to her and says, well, what if your goal is to live as long as possible, even if it means being in the ICU? And then Diane said, this is paraphrasing, then they go to the ICU, but you know that you've had that conversation. So I think that's a part of it too. And one piece that seems to me to be potentially missing from the respecting, I actually don't know, maybe you could tell me if it's part of respecting choices, is that my goals will differ if I have 10 years to live versus 2 years to live, right? And so if there's a conversation about preferences for CPR that is missing that key piece that should come first about prognostic awareness and discussion, then it might lead to goals that are associated with hey, if I'm going to live 10 years, these are the sort of things I want. If I'm going to be fully functional for as long as possible, absolutely, intubate me, bring me back, those sorts of things. I'm interested, how does that ring to you? What do you think? Is that fair? Is that unfair? Danny, I see you're ready to go. What do you think?
I'm ready-ish to go. I mean, I'm of the mind that knowledge is power. And I think these and I mean that in a way that these conversations are designed to not just be had in isolation between a primary care provider and a patient. The idea, we tried to push this as much as possible, is that you're informing the people around you, the people who might be making those decisions. And I think, in terms of advanced care planning, having those conversations early, there's a timing element to this as well. We talk about, there'd be a difference between having a person who's 65 and relatively healthy having these conversations versus someone like in our study who has a serious illness, who, has probably had conversations about prognosis and is able to, kind of say what they want. And the respecting choices it does sort of try to meet people where they live. And so I'm actually looking at it now. I pulled up the conversation guide while we've been talking, and it very much has things like, tell me where you're at. Do you have any experiences with being seriously ill or people that becoming serious ill? And then it moves into explore what living well is. What is living well for you? What is a good day a healthy day? What would happen on that day? And, what does it mean to you to have those days? And it's all trying to get people to contextualize this thing. So to get towards the bigger topic, and the controversy, I guess, and this is just my opinion, it's a small one, but, I just think that there is nothing wrong with having these conversations often, making sure that they're readdressed, and just making sure that the people that are involved in your life know these things, because I think the issues come up when there's no one to speak for you. And I know there's a lot of complexity under that, but that's sort of my initial reaction.
Sydney, any other thoughts? Oh, go ahead, Jasmine.
All I was going to say is that I agree with Danny, and I think it's key to remind people to just revisit their plans regularly, because what you want to avoid is not being prepared in high stress situations.
All right, I'm going to ask each of you, like, when you think about the implications of this study, what are they? Because this is not a cost-free thing, is that you have to get facilitators. You have to do this. It does increase advanced care planning documentation, but for a healthcare system, it actually increases potentially burdensome treatment a lot. Maybe goal-aligned care, but potentially costs too. Is this a study that is negative? It doesn't work, or actually may make things worse? Is this something that we should implement? How do you think about this? I'm going to turn to Jennifer, you first as the first author. What's the implication?
Well, I think that there are a number of really important implications in terms of thinking about the way we design and fund studies. And as I mentioned, this study was proposed in 2018 before COVID. The world is vastly different today than it was in 2018. I have increasingly become very interested in the idea of doing research quickly, sort of rapid cycle testing, failing fast. And so I think that the availability of technology is increasingly making it more possible to think about designing studies where we have real-time data collection and can pivot quickly.
So let me ask you this then, Jennifer. If you were the healthcare system boss and you had to decide, should I implement this or not? Would you say we just don't have the studies to show yet that this is effective?
I would say that on this particular study, I would say we don't have enough. Yes, on this particular study, but I think that we went into this really wanting to focus on people with dementia. And I think that what we did learn is that normalizing important communication processes for everyone doesn't necessarily meet the needs of the people who are the hardest to find and who need the most support.
Mm-hmm.
Great. Danny, what do you think the implications are?
Yeah, I think it's two-pronged. I mean, this is sort of, behind the scenes a little bit, but what was very interesting is that one of our organizational partners, when we finished this, I'd say both actually, but one that surprised us, actually adopted the ACP facilitator model. And they adopted just in sort of enthusiasm and what was happening, the time that it saved providers to have the conversations. Sustainability was another question, but there was enthusiasm for it. And for the providers that we were able to engage, again, there was a lot of complexity around this with the remote nature of it. They really enjoyed it. They liked that these conversations were happening and that they could kind of pick up the baton later, during another kind of visit. But in terms of implications, I think for me, the thing that's stayed with me is that it's cool that we had such a strong effect on one, and it's puzzling that we didn't on the other. And as Jennifer sort of alluded to, we're doing a little bit of work now in our no-cost extension time to kind of investigate this stuff. So for me, it's always going to be a piece of like how, and it goes back to the design that Jennifer was talking about, how can we either design in the future, or with the data that we have, how can we look for like markers of why we're seeing these things? Because they are what they are, but I don't know that it's concrete enough. Even if we found a positive effect, I think we'd have to be very tentative about how we presented the implications. And so, you have to dig into what it is, the goal concordance of it, the complexity of these interactions happening in primary care. All of that. So, I guess it's sort of a little bit of a teaser for work that we're doing, especially a paper that I'm leading that Jennifer was talking about earlier, that's kind of trying to dig into this a little bit more, with nothing, just to try to understand. So, okay.
I got to go because we're running close to the answer. I'm going to go to Sydney now. Sydney, if you had a limited budget, would you spend your palliative care budget on this intervention, given that it increased advanced care planning documentation, but it worsened potentially burdensome interventions at the end of life?
Yeah, so there's 2 points. It's really important that we bring these conversations up early, that we make it available for people when people are healthy, but it's also incredibly important that we have services, supports to take care of people when they have serious illness, to care for them, to do all the other things that will help to avoid them from having these things done, and to have conversations with them how they want. So it's really important to do both.
So you would this particular intervention with these results, it's important to have it.
This is what I do as a primary care and palliative care physician. I think it's important to do both.
Yeah.
That we offer both aspects to people.
All right, Jasmine.
Yeah, even though you didn't find the findings that you were expecting, I still think it's important to have these types of interventions. I think expanding it to non-English speaking populations would have been great to include, but maybe that's for a future study. But yeah, that's all I'll say.
Wonderful. Well, we're at the end of the hour. I want to thank all of you for being on. But Alex, can we get what's the title of the song, Jasmine?
Laka laka.
Tuku tuku tiki taka, que rankahi hakalaka. Cuando menos lo pensemos, nos hace estirar la pata. Yo me escapé una vez, pero por poco y me atrapa.
Jennifer, Sydney, Danny, Jasmine, thank you for being on the Jerry Pal podcast.
Thank you very much.
Thank you.
Thank you.
Thanks. This was fun.
And we are looking forward to all of those follow-up studies to help answer some of these questions. And with that, thank you very much. And thank you to all of our listeners for your continued support. And we'd like to send a special thank you to all of the donors who've donated more than $250, including
Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, and Paul Amatelli.
Thank you very much for your support.